Okay. Good afternoon, ladies and gentlemen. My name is Jim Yang, President of APASL. Thank you for joining today's APASL COVID-19 vaccination webinar. This is the second of the APASL webinar this year. First of all, my special thanks go to the moderator, Professor George Rao from the Queen Mary Hospital, Hong Kong, who has always given us his strong support as well as valuable advice. And I am very fortunate and grateful to be able to introduce Professor Woo-Joo Kim from the Division of Infectious Disease, Korea University. Professor Kim is the most renowned expert about pandemic infectious disease in Korea, such as MERS, COVID-19, and flu, and so on. And he'll be sharing his profound insights on COVID-19 vaccination. And Jimmy, could you please slide? Yeah. And I'd like to introduce what was decided about COVID-19 vaccination in liver disease at the previous Global Hepatology Society Summit. One, we strongly recommend that all patients with liver disease, viral and non-viral disease, including fatty liver, undergo immunization with any authorized COVID-19 vaccine that is offered to them. Two, we recommend that patients with advanced chronic liver disease, liver cancer, and those post-liver transplant should be prioritized for vaccination for COVID-19. Three, whilst the vaccine trials have not comprehensively evaluated safety in patients with chronic liver disease, there are no data to suggest that COVID-19 vaccines cause any adverse outcomes in this group of patients, including organ rejection or flares of autoimmune disease. Four, only by achieving global coverage can we succeed in our battle against COVID-19. We therefore encourage governments to ensure vaccines are distributed to low and middle income countries to provide equitable access. So finally, I would like to thank the member of the webinar program committee and the Professor Young-Suk Lim, is the chief of webinar program committee, for organizing such an interesting program. And I hope all of the participants to gain a better understanding on COVID-19 vaccination, especially in patients with liver disease. Thank you. So, Professor Kim, please.
I'm Woo-Joo Kim, co-chair of this APASL Hepatology webinar, Episode 5, COVID-19 vaccination in patients with liver disease. I'm very honored to participate and co-chair of this session. I'd like to thank to the presenter, Professor Yang, and steering committee and program members. I'd like start thanks to the speakers, panelists, and online audiences. I encourage many participants and online audiences, please ask and question on the chatting window or Q&A part. So I would like to introduce first speaker, who is the Professor Won-Suk Choi. He graduated Korea University Medical School from 2002, and he got the PhD degree in 2009 in same university. He is very active in the immunization vaccination program, and he is very well-known advisor to the Korean government to COVID-19 vaccination campaign. So he's now working at the Professor, Division of Infectious Disease, Korea University, Ansan Hospital in Korea. So I would like to ask his presentation. Title of his presentation is Overview of COVID-19 Vaccines Available and Under Development, Types and Mode of Actions. Please, Professor Choi.
Okay, thank you for introducing. Good evening, good afternoon, and thank you for inviting me to this seminar and giving me the chance to lecture. I'll share my screen. Okay, I want to take a look at the overall contents of the COVID-19 vaccine. In particularly, I will give a lecture focusing on the type of vaccine currently being developed or used and the mode of action. As you know, the pandemic experienced by mankind is very diverse. The COVID-19 is located on the eighth among the many pandemics humanity has experienced in terms of death toll. However, considering the fact that we are living in the very advanced circumstance, medically and technologically, we can think that the significance of the COVID-19. As you know well, COVID-19 was first reported in December 2019 in China. WHO declared the international public health crisis on January 31, 2020, and on March 11, the global pandemic had declared. It was the third pandemic, as you know, since the establishment of the WHO, and it was the first to be a pandemic declaration due to coronavirus. When such a pandemic or epidemic occurred, the demand for the rapid vaccine development emerged. However, it is very difficult to develop a vaccine immediately after the infectious disease is recognized by traditional methods. The live attenuated vaccine, which is the most traditional way to make the vaccine, generally bear the risk of reversion and reinfection. So this approach is unfavorable for highly pathogenic organisms like SARS-CoV-2. Inactivated vaccine is also the traditional way to make the vaccine, but the platform may not induce the enough protective responses or induce the exacerbated disease. Another concern is the need for the ability to produce large amount of vaccine. So we need a way to develop a large amount of vaccine in short amount of time with low cost. Therefore, various new infectious diseases have been attempted to develop vaccines using various platforms in addition to the traditional methods like mRNA vaccine or virus vector vaccine. That is, we are currently using as a method for the COVID-19. One of the good situation in the development of the vaccine for SARS-CoV-2 was that the spike protein, we know the spike protein, the site that binds to the receptor when the coronavirus enters the cell. And the spike protein is very important, and this site is the major target for the vaccine. It was recognized early stage that it was easy to speed up the development of the vaccine. In addition to the recognition of the target site, even if the duration of clinical research remains at the same time, required for the vaccine development can be greatly shortened by reducing the time required for review by regulatory agencies, and allows the clinical trials of each phase to be overlapped and carried out in succession. As the COVID-19 vaccine development began, the WHO presented a target product profile for COVID-19 vaccine development in April 2020. Its vaccine manufacturer has conducted clinical trials in accordance with this TPP, and critical criteria, as you can see, served as a minimum criteria for approving for the vaccine. The TPP includes a variety of vaccine characteristics, but in terms of measures of efficacy, over 50 was required for the minimum requirement. and the duration of the protection was at least 6 months. Currently, there are about 10 vaccines, about 10 or 12 vaccines in use worldwide, but 90 vaccines are entering the clinical trial stage, and over 20 vaccines are entering phase 3 clinical trials. In the case of drugs that have entered phase 3 clinical trials, it is expected that more than 70% come to the success stage. So we can expect that in near future, we can have various kinds of vaccines. As explained earlier, the major target of the COVID-19 vaccine is the spike protein. An immune response to the spike protein of the SARS-CoV-2 must be induced to prevent the disease by the virus. And there are two ways to induce the immune response to the spike protein. The first is that to put the spike protein directly into the body. Inactive vaccine and the protein-based vaccine used this mechanism. The second way is to put the spike protein, the blueprint, the gene into the body and have the body make the spike protein directly. Genetic vaccines, including mRNA and DNA, or viral vector vaccine work like this way. First, let's look at the inactivated vaccine. The inactivated vaccines are made with the direct use of SARS-CoV-2 virus. The virus is inactivated using substances such as beta-propiolactone or formalin. The inactivated virus could no longer replicate after this stage. But the protein, their protein including spike protein, remained intact in the virus. So the inactivated virus can make the immune response by the body. But for the enough immune response, we need adjuvant such as alum. The Beijing Institute of Biological Products created an inactivated coronavirus vaccine that was put into clinical trial by the state-owned Chinese company named Sinopharm. Chinese government gave Sinopharm emergency approval in summer of 2020, and on December 30, Sinopharm announces that the vaccine had efficacy over 79%. And the WHO put forward similar efficacy estimates and gave the vaccine emergency use authorization. The Sinovac, another private Chinese company, developed an inactivated vaccine called CoronaVac in early 2020. In early 2021, the trial in Brazil and Turkey showed that it could protect against COVID-19, but they showed that quite different results, 50.65% or 91%. The next is protein-based vaccine. As I explained earlier, the protein-based vaccine is a method of synthesizing spike protein externally and use it as an antigen. To create the vaccine, making the vaccine started with a modified spike gene. The gene is inserted into a different virus like baculovirus and allowed it to infect most cells. The infected cells produce spike protein that spontaneously join together to form the spikes. The spike proteins are harvested from the most cells and assembled into nanoparticles. While the nanoparticles mimic the molecular structures of the coronavirus, so they can, but they cannot replicate or cause the COVID-19. The Novavax vaccine is a representative protein-based vaccine. On March 11, Novavax reported that their UK trial determined an efficacy rate over 96% against the original virus. So, but In South Africa, the volunteers were exposed to a more contagious variant. The result was roughly 55%. So the company is developing a new version of vaccine that is tailored to the emerging variants. The following is the first mRNA vaccine to be used worldwide. The mRNA vaccine, in fact, the mRNA vaccine was not the first method used to develop the COVID-19 vaccine. The first of the successful use of in vitro transcript mRNA in animal was published in 1990. But the result did not lead to the investment in developing mRNA therapeutics or vaccines, largely owing to the concerns associated with the instability, high innate immunogenicity, and inefficiency in vivo delivery. But the mRNA vaccine has several advantages that was safety, efficacy, and potential for mass production. In fact, there was a record of attempt to develop mRNA vaccine against HIV, rabies, Zika, and influenza viruses, and that was entering clinical trial stage. The vaccine uses messenger RNA to make the spike protein. As you know, the messenger RNA is very fragile and would be easily destroyed by the enzyme. So to protect the vaccine, the mRNA is wrapped into oil bubbles made of lipid nanoparticle. After injecting, the vaccine particle bump into cells and fuse to them, release the mRNA, and the cells molecules make the spike protein use the mRNA sequence. The Pfizer's mRNA is currently one of the most used COVID-19 vaccines worldwide. It is supposed to be inoculated twice, and the inoculation interval is 3 weeks. On December 8, the FDA released the analysis of the clinical trial, and determined the trial efficacy was over 95%, and the study published by CDC was 91.3%. As I know, on May 7th, the Pfizer announced that they would seek the full FDA approval for their vaccines. Moderna's vaccine is the second mRNA vaccine to be used worldwide. It is also made up of 2 doses, and the interval is 3 weeks. It is not known specially how the characteristics of the vaccine manufacture differ from the Pfizer, but it has the advantage that the storage conditions are less demanding that compared to the Pfizer vaccine. The next is a viral vector vaccine. The viral vector vaccines are divided into 2 types, replicating or non-replicating vector. Various viruses can be used as vectors, but adenovirus is most widely used among them. Viral vectors have been used in development of various vaccines since the past because the viruses are an excellent transporter for transporting genetic materials into cells. Adenovirus vectors have been used not only for the vaccines against infectious disease, but also used for many kinds of cancer treatment. The virus vector vaccine platform is very similar to the genetic vaccine, except that it used the adenovirus as a vector. The adenovirus used here is a non-replicating vector. When the gene of the spike protein is inserted into the adenovirus and inoculated into the human body, the virus enters the cells and creates the spike protein, and the immune response is generated. The AstraZeneca's COVID-19 vaccine is the first COVID-19 vector vaccine to be used. It is supposed to be inoculated twice, and based on the result of the study, that the vaccine efficacy is better when the vaccination interval is increased to 12 weeks. The vaccination is currently administered every 8 to 12 weeks. The J&J vaccine is a vaccine that has been approved for the use following the AstraZeneca vaccine and is intended to be administered once. But there are still some area of uncertainty regarding to the long-term preventive effect. Let's see the comparison of the vaccines. This shows the vaccine manufacture methods. Each vaccine differs in its manufacturing methods, especially the mRNA vaccines are known to be able to manufacture and scale up in the short time compared to other kinds of other platform of vaccines. And this slide shows the various vaccines and the result of clinical trial and immune response. And as I know, you can hear the next lecture about the clinical trial results. One study compared and showed how well each vaccine met the TPP proposed by WHO. As you can see, the mRNA vaccine and the protein-based vaccine scored the highest level in that study. Currently, the part about variant remains in the area of uncertainty. Accordingly, each company is taking various strategies to respond to the variants and is trying to develop new vaccines for booster shots or variants of the same vaccines. However, I think that we can see the real strategies, what strategies will be good for combat to the variants in soon. Thank you for your attention. That's all of my lecture.
Thank you very much, Professor Won-Seok Choi. He presented very concisely and nicely about many different type of emergency approved COVID-19 vaccine from 4 vaccine platform. So I think it's a miracle to develop at least 8 COVID-19 vaccine within 1.5 years since emerging COVID-19 pandemic. So I would like to move quickly second speaker, who is Professor Kwon Ki-tae, who is the professor at the Division of Infectious Disease in Gyeongbuk National University Hospital in Daegu in South Korea. He graduated medical school from Gyeongbuk National University in 1997 and got a PhD degree from same university in 2007. He is very active in the infectious disease field, and he is very energetic and actively participate to take care of the patient during the Daegu Gyeongbuk COVID-19 outbreak in February, March of last year, which is a big first outbreak in South Korea. He is now a professor at the Division of Infectious Disease, Gyeongbuk National University Medical School, Daegu, South Korea. So title of his presentation is Efficacy and Safety of COVID-19 Vaccines Available. What is known and what is unknown? Professor Kwon, please.
Thank you for a nice introduction, Professor Kim. I appreciate inviting me as a presenter in this excellent conference, and I will share my slides. Okay. Today, I'm going to tell you about the efficacy and safety of COVID-19 vaccines, especially including the clinical trials and what is known and what is unknown. Actually, I'm preparing these slides, including most of them are what is known, because I don't have an answer about the what is unknown. So today I will tell you about the what is known mainly. Sorry. Okay. This is a let me tell you about the vaccine license and usage status. For Pfizer vaccine, has been approved and used in 82 countries. And for AstraZeneca, the 105 countries has approved and used. So most of the countries in the world are using AstraZeneca vaccines now. And the next, the Moderna vaccine has been approved and used in 35 countries, and rest. The next is the Russian and the Chinese vaccine has been approved in about 20 countries respectively. Professor Che in the previous lecture mentioned most of the effectiveness, efficacy about all the available vaccines. So I just want to briefly talk about this table. And it's easier for me to talk to name the vaccine which was manufactured. Manufacturer's name is easier for all of us, so I prefer to call the vaccine as a manufacturer's name, because the original name of the vaccine is more difficult for me. So the important thing is that the efficacy against the severe COVID-19, regardless of the vaccine types, platforms, almost 100% of the severe COVID-19 pneumonia can be prevented by the vaccines. These are most important thing, I think. And overall efficacy is varies between vaccines. Some vaccines, 90%, mRNA vaccine has the highest efficacy at 90%, over 90% after second dose. And adenovirus vaccine, which was manufactured in Janssen, it can be used with one dose. It's about the 62 preventive efficacy against of 60 to 70%. And another adenoviral vector vaccine, which was manufactured by AstraZeneca, has the between 60 to 70% efficacy against COVID-19 after second dose. And protein subunit vaccine, which was manufactured by Novavax, has the preventive efficacy against COVID-19 of about 90%, and 60% in about against the South African variant. And Sputnik V, which was manufactured by the Russian pharmaceutical company, has the preventive efficacy of about 90% after first and second dose. And I want to talk about the mRNA vaccine data at first. This is the data about the already many of you knew, I think, Pfizer vaccine clinical trial. The total number of participants were 43,000, and efficacy, preventive efficacy was the 95%. And in the subgroup analysis, according to the age and ethnicity and underlying comorbidities, there is no difference between each subgroup. And as I mentioned already, the efficacy to prevent the severe disease was 88.9%. This is a kind of beautiful picture to show the efficacy of the Pfizer vaccine. I think many of you already saw this slide. So after first dose, 2 weeks after, and the incidence of the COVID-19 cases difference was huge. So the very efficient vaccine was approved in in this clinical trial. Let me talk about the solicited local events within 7 days of vaccination. And there is no big difference between younger age and older age in the local solicited event. And there's no big difference between first dose and second dose as well. But solicited systemic event after first dose in younger age, the reporting rate and adverse event rate is a little higher than the older age in the systemic event. As you know, the fever and use of antipyretic medications is a kind of the objective index for the systemic adverse events, and especially in these two indices are higher than in younger ages than in older ages. And solicited systemic events after second dose, the rate of the adverse event in the systemic events much higher than the first dose in first dose. So, and in younger age, the rate of the adverse event is the higher than in the old age, especially in the fever and use of antibiotic medications. So, in the Pfizer vaccine, systemic event, local events, the difference between AG and first and second dose is not so high. But in the solicited systemic events between younger age and between young age and old age, and first dose and second dose showed that the higher in the younger age and after those two. And let me talk about the second mRNA vaccine, which was manufactured by the Moderna. The vaccine efficacy was similar with the Pfizer vaccine, but in the older age, the efficacy was a little lower than the in the younger ages. This is usual finding in the, I think the in other vaccine clinical trials. In the subgroup analysis, similar to the Pfizer vaccines, according to the ages and ethnicity and the risk factors, there is no difference between the between the subgroups, and the efficacy against severe pneumonia, the 100% is very high. Already I mentioned in the second slide. And the next, let me talk about the adenovirus vector vaccine. This is the the AstraZeneca vaccine. The overall efficacy was about 70.4%. And accidentally, the clinical trial used half a dose in 1 month in first dose and full dose in second dose. The efficacy was very higher, but was not. They can't. The reason why the half dose and second full dose cycle, the efficacy of half dose and full dose cycle was much higher than the regular doses. And solicit the local event with 7 days after standard prime dose, the pain and tenderness were the most frequent adverse event in the local solicited event, and second and third day after the vaccination has the highest rate of the local adverse event. And days after prime vaccination, the rates, the systemic events, solicited systemic event with 7 days after standard prime dose was in old age, the rate is a little lower than the younger ages, as the similar with the other vaccine studies. In the solicited systemic events within 7 days after standard boosting dose, this is kind of the unique finding, I think, because days after booster vaccination, the rate of the systemic event was lower than the first dose, regardless of the ages. It's a little different from the Pfizer vaccine. Pfizer vaccine had, in the second dose, the rate of the solicited systemic event was higher than the prime dose. But in AstraZeneca vaccine, second dose has lower solicited systemic events than in the first dose. Let me tell you about the another adenoviral vector vaccine, which was manufactured by the Janssen. The total number of the participants were 44,000 and 44,000, and efficacy at day 28 post-vaccination was the 67% overall. But as I mentioned in the table, summary table about the efficacy, the Janssen vaccine also had high of 75% effective in preventing severe and clinical disease and complete protection against the COVID-19 related death. So this event, adverse event after first dose, and in younger age, the event rate are higher than the old ages. Local events also had a higher adverse event rate in younger ages than old ages. These days, as you know, the problem is the increasing rate of the virus variants. These are summary table about the several vaccines had the lower efficacy against some variants, especially B1351 variants had the lower in B1351 variants, the vaccines has lower efficacy than in regular virus. So, but Pfizer and Novavax has a little higher efficacy against the variants compared to the other vaccines. AstraZeneca vaccine has the almost less effective in South African variants. Let me talk about the real-world data about the after post-licensure monitoring. These slides are about these summaries of the real-world data about Pfizer vaccines. For deaths, the preventive effects was almost 100. It's very perfect. It's similar with the clinical trial, and severe disease and hospitalization has also almost a perfect efficacy. Is also similar with clinical trial, and symptomatic disease also in symptomatic disease, the efficacy of the vaccine was similar with the clinical trial. But asymptomatic infection, we don't know exactly how much it can be prevented in asymptomatic infection, but in some data are showing that the efficacy is a little lower than the symptomatic or the severe or death. From 50 to 90% is have some variations between in each studies. Together, combined Moderna and Pfizer vaccine effectiveness, also similar with the clinical trials for hospitalization and death, and for infections. about the 90% from 90% to almost 100. This is the share of people who received full vaccinations. Israel has the highest vaccination rate all over the world, about 60%. United Kingdom is the next, is 50%. United States and Chile has about 45% vaccination rate. In Germany is about 30%. The all over the world, and South Korea has about the 8 to 9%. This is the number of patients per million of the population per day. Israel has the highest. Israel has a rapid decline, most rapid decline from top to almost lowest. So Israel has very succession of the vaccination policy for their population, and United Kingdom and United States also declined, has the declined so much from a very high rate of the confirmed cases in the past, but now has very lower confirmed cases compared to the past. And let me talk about post-license safety monitoring. This is the American Vaccine Safety Monitoring System, which in Korea we have a very similar system, and other countries also has the similar systems, I think. VSafe is an active surveillance system, and VAERS is a passive surveillance system. And there is also the CISA project, which is an individual case consult. And there is also a large linked database monitoring system. And many countries have, I think, the similar systems about the post-license safety monitoring. So let me show you about some data of the safety monitoring with local and system reactions by VSafe. This is kind of the active surveillance monitoring. When looking at the types of adverse reactions, injection site pain is the most common, followed by fatigue and headache and myalgia, chill, and fever. In the case of fever, in the case of fever, which is in the case of fever, which is the objective adverse reaction, Pfizer vaccine showed the first vaccination has the 5.8% of the adverse reaction rate with fever, but in the second dose, almost 5 times higher, was the 29% of the fever rate. This slide shows the anaphylaxis of the Pfizer and Moderna vaccine. The rate was 4.7 per million doses in Pfizer and 2.5 in Moderna. All 67 persons were treated with healthcare settings, and no deaths from anaphylaxis after vaccination with either product were reported and recovered fully. In Korea, we have similar reporting system. I will show you some data about vaccine adverse reaction report in Korea. This data from February 26th to May 8th. A total of 4,170,000 people were vaccinated in Korea. The reporting, this is not this is just the reporting rate from the people. The causality was not assessed in this table, so you need to be very careful to interpret this table. This is just reporting from the medical institution. The total adverse reporting rate of the adverse reaction was the 0.47%. The anaphylaxis rate was assessed by the causality. The true number of anaphylaxis was 30. So the rate of the anaphylaxis per million in Korea was 7.1. It's a little higher than the America in the previous table, which was shown as 4 or 4.7 or 2.5. In AstraZeneca, the rate of the anaphylaxis rate was a little higher than the Pfizer, which was 2.87 per million. So the rate of anaphylaxis in Pfizer vaccine was a little lower than the United States. This is the causality assessment result of severe adverse in South Korea. The total number during this period was the 156, and finally only 2 cases, it's just 1.3% was resulted in related to the vaccine by the causality assessment. This is vaccine adverse reaction reports in United Kingdom. Total rate. I'm sorry, I want to tell you about something more about the report in South Korea. The rate of the adverse reaction in AstraZeneca was 5 times higher than the rate in Pfizer vaccine. Is very high, higher in AstraZeneca than in Pfizer vaccine. But in the United Kingdom, the rate of the adverse reaction report in AstraZeneca is 0.7, then 0.5 in Pfizer. It's not so different than in Korea. But the rate of anaphylaxis, this is just, I think, the reporting rate, not assessed by the, assessed causality, not has performed by the, I'm sorry, causality assessment was performed, I think, just the reporting rate. So the rate is much higher than the States or in Korea. This is some information about the thrombotic thrombocytopenia syndromes associated with replication defective adenoviral vector SARS-CoV-2 vaccines. Incidence rates usually estimated 1 case per 100,000 to 250,000 per vaccine recipients. And the age range has 21 to 77 years, usually 90% less than 60 ages, and female has more than the male, 2.5 to 1 ratio, and median onset was 10 days. And thrombotic event can have in thrombotic event was in cerebral venous thrombosis or deep vein thrombosis, abdominal vein class, or sometimes can be developed in arterial clots. Predicted factor IV antibody can be positive, which was a diagnostic indicator, and the platelet number can be very low, and D-dimer usually increases very high, and heparin can aggravate the disease, and intravenous immunoglobulin can be used for platelet recovery. And I will just briefly, very shortly, talk about what is unknown. This is all about unanswered questions, which is prepared by me. The primary endpoint in mRNA vaccine trials were just symptomatic illness. Therefore, not yet known if these efficacy these effectively prevent transmission. And duration of vaccine immunity is still unknown. And long-term safety data will require years of vaccination follow-up, but we can have just only several months follow-up data about the safety. And no data yet on efficacy or safety in children and pregnant women. As I know, in the States, some data is being accumulated in the States about the children and adolescent. And lower than 200 participant trial developed symptomatic COVID-19. That is to say, too few to draw conclusions about efficacy in subgroup populations. And SARS-CoV-2 genome appears relatively stable, but not known how virus will respond to selection pressure of mass vaccination. Thank you for your attention.
Thank you very much, Professor Kwon. He summarized the safety and efficacy of clinical trial of vaccine against COVID-19 virus, as well as real-world safety and effectiveness data. Thank you very much again. I would like to hand over chairmanship to Professor George Lau.
Thank you, Professor Yan and Professor Choi. The two talks are really excellent in terms of giving us overviews of what the type of availabilities of COVID-19 vaccine and also efficacy and safety of the vaccines available. Now, without undue delay, I would like to introduce our next speaker, Professor Grace Wong from Chinese University. Professor Grace Wong graduate from Chinese universities with honors, and she has involved in a lot of very important studies in terms of liver diseases and also gastrointestinal diseases. Professor Grace Wong have published more than 414 papers and with the citations of more than 11,000. The H index is 61. And I would like to have Professor Grace Wong, our actually newcomers and leaders in hepatology from Hong Kong and China, to talk about very important topics, and that is what is the benefits and risk of COVID-19 vaccinations in patients with liver diseases, and what do we know to date, and how to counsel and manage our patients. Professor Wong, please.
Thank you, Professor Lau, for your very kind introduction. Good evening, friends and colleagues from different parts of the world. I'm truly honored to be invited to be one of the speakers on this very hot and important topic. The two excellent speakers just now have already provided a lot of data about the vaccines. So now I will more focus on patients with liver diseases. So some of my personal disclosure. I would like to highlight that in our region that we do have a lot of patients with chronic liver diseases like chronic hepatitis B, hepatitis C, alcohol liver disease, non-alcoholic fatty liver disease, or recently someone named it metabolic related fatty liver disease. So in our region, we do have the largest number of patients, populations affected by liver diseases, as shown in this very important review article written by Professor Sarin and his team. So I think that's why this topic is so relevant in our regions. I would also like to share with you one of our studies published early last year, talking about the importance of liver injury in COVID-19 patients. That in fact, this is something quite prognostic. We are referring to patients after getting COVID, they will have liver injuries as evidenced by increase in their liver enzymes, at least like ALT, AST are more than 2 times of the normal. In fact, such patients will have increased risk of ICU admission, use of mechanical ventilation, and death. In fact, the odds ratio is as high as 7.9 after adjusting for other covariates. So that's why liver injury in COVID is something important and prognostic. And this is also shown by other groups showing that the presence of chronic liver disease and cirrhosis, in particular those with decommon cirrhosis, is something very important that will dramatically increase the case fatality rate. And also someone may develop new decompensation during the disease. So that's why liver is so important in patients with COVID. So in fact, we have gathered a group of experts last year to publish this position statement to talk about how to manage a patient who have liver disease or who develop liver injury. I would like to highlight that, in fact, in patients who are admitted for COVID, in fact, we should at least have some basic workup, at least check their liver biochemistry. If they do show some liver injury like raise in liver enzymes, we should provide some basic workup like check for viral hepatitis and then monitor their liver function, and be very cautious when we use some drugs which may be potentially hepatotoxic. And then we also need to be careful when we use some off-label treatment for COVID, and we may advise to regularly monitor the liver function of patients who have abnormal liver biochemistry at baseline. Okay, now go to vaccine. I think we already learned a lot from the experts just now. We have different platforms, different efficacy data, and so on. I would like to highlight that concerning safety in general, the safety is quite favorable. And as listed here, three of the vaccines that quite commonly used in different parts of the world, you will appreciate that among the listed worst event, in fact, liver is not really on the list. So in fact, there has been no obvious signal about any obvious liver side effect, liver adverse effect that have been reported in different trials. And also just now already pointed out by Professor Kwong that are very rare but very important conditions, that thrombosis and thrombocytopenia. And at least from this report published in the New England Journal of Medicine, they listed a lot of characteristics. And I would say that in fact, all these kind of thrombosis and thrombocytopenia is not really related to liver disease. It's just maybe someone may say female may be at risk, someone would say that as some other characteristics, but at least liver is not one of the risk factors for that. And in fact, IVIG will improve the platelet count quite quickly. So likely this is something immune mediated. Okay, I think a very simple and straightforward answer to this patient is a big yes, because we know that COVID vaccine is important to reduce infection, as well as to not just protect the patient who get the vaccine, but also the people around that person. So I think vaccination, in fact, should be offered to essentially most of us. And for our liver patient, I would say it's a big yes. And in fact, many studies showing that in patients with comorbidities, in fact, the safety efficacy is just as good. So like in this report, they try to look into different subgroups that including age, gender, comorbidities. In fact, the efficacy would be just as good as in other groups. And in fact, some like our international society already published some kind of statement supporting vaccines in our liver patients, and they emphasize the remarkably safe and highly effective vaccines. And in this American one, they highlight the mRNA one because that's have been very commonly used in their country. And then they were advised to be given to all adult patients with liver disease or liver transplant recipient. Concerning the dosage, up to just now, at this moment, there will be no particular recommendation for different dosing. I would say that all of us will use the standard dose. Even in some other vaccine study, they may recommend a double dose in other diseases. But I think for COVID vaccine, up to this moment, there's no evidence saying that double dosing is helpful or needed. And someone are quite concerned about allergy. I think up to this moment, the obvious allergy we need to pay attention to would be allergic to PAC. So if someone really have previous allergic reaction to PAC, then probably this type of mRNA-based vaccine should not be used. And obviously, if they have very strong immediate allergic reaction to the first dose, then they should not receive the second dose. And concerning the variants, we have very detailed discussion just now. And even though there may be reduced response, but it's still protective. So we would say that variants should not be a reason to withhold vaccination. In fact, we should keep vaccination going, even we found variants in that parts of the world. And the interval would be minimal 14 days. In some parts of the world, like in Hong Kong, we use at least 21 days for mRNA-based vaccine, and for a Sinovac vaccine, we put it as 28 days. Some other parts showing that even prolong it longer, like up to 2 to 3 months. In fact, the response may be even better. And concerning priority, then definitely patients with chronic liver disease should be prioritized for vaccine. And quite a lot of discussion about transplant recipients because they are receiving immunosuppressive agents. In fact, these type of patients would need the protection even more. So we strongly advocate them to receive the vaccine. But if they are going to receive a transplant very soon, they are a pre-transplant candidate, then they, after giving the first dose, and then if they need the transplants, then we need to postpone the dosing a little bit, hopefully maybe 6 weeks after the transplant, because at the early days after transplant, they use very, very intensive immunosuppressive therapy that may reduce the response a bit. So ideally, hopefully it will be 6 weeks after transplant, then we give the second dose. And for consumer medications, there's no obvious interaction between antiviral drugs or any drugs used for PBC or autoimmune hepatitis. So all the drugs should be continue as usual. And for HCC patients, even though they have been receiving some treatment, be it local, regional, or systemic, even the immunotherapy these days have been used a lot. In fact, all these treatments should be continued without any interruptions. But one thing is that if the patient do have recent infections or fever, then they should have the vaccine defer a bit until the acute infection has been settled, the fever has been settled, and become medically stable. And concerning the reaction, so far, the reaction probably is quite as usual as in other types of patients. So there's no particular safety signal in patient with liver disease. And obviously, the patient should keep doing all those social distancing, masking, hand washing. All these should be continued, even the patient already received vaccines. And I think ESOs have very similar recommendations. So again, essentially vaccine for all patients with chronic liver disease, HCC, transplant. And they also advise to prioritize the household members of such patients because they are staying together. They want to protect the patient by vaccinate the household members, and they also advocate to have some prospective registry to monitor the safety because liver patients are quite underrepresented in the previous trials. I think immunosuppressed patients has always been one of the concern. I think not just in hepatology, but maybe also in rheumatology, HIV, or any types of immunosuppressed patient. Many people are very concerned about whether the vaccine will have more side effect or maybe the efficacy will be reduced. So I would say that up to this moment, there will be no very solid evidence. In general, we believe that immune response may be slightly reduced, but they can still be protected or get benefit from getting the vaccine. So I would say that in general, we believe that even patients are immunosuppressed, we should offer the vaccine to them. And then we may also try to adjust the timing of some drugs. These are the experience from other vaccines, like from the flu vaccines. So they would say that probably we can withhold methotrexate for 2 weeks after the vaccine, or for rituximab, which is another very potent immunosuppressive therapy, again, maybe try to schedule it with a longer interval, maybe a few weeks apart, hopefully can really get a better vaccine response. And in fact, another very important paper from this Lancet GastroHep, in fact, they also listed quite a lot of key points and some outstanding questions. I think that can also supplement Professor Wong's talk about what are unknown. I would say that, in fact, here they listed the key thing is in the previous trial for various vaccine. In fact, liver disease are even not defined, not included, underrepresented, something like that. So we do not know the magnitude as well as the duration of vaccine response in such patients, as well as the disease severity, like how bad the cirrhosis would it affect the response, as well as is there single doses, booster, something like that, as well as any vaccine-related liver injury. I think all these remain unknown or lacking sufficient data to support that. And quite similar for liver transplant subject, because I think all of such patients were not included in those phase 1, 2, 3 trials. Maybe some data from real world registry, but not in the trial. So again, they are underrepresented. I think the major concern again would be the efficacy of the vaccine in such immunosuppressed patients. Similarly, for other type of liver disease which warrant immunosuppressive agents, again, all these patients have been excluded in most of the trials. So again, we do need some prospective registry to kind of collect more data to know about the efficacy as well as the safety in such kind of patients. So in conclusion, Chairperson, ladies and gentlemen, I would like to highlight that benefits obviously outweighs the risk in our liver patients if they're going to receive COVID vaccine. So it would be a big yes to tell our patients they should all go to receive the vaccines. And concerning how to counsel them, in fact, I think we are all very experienced on handling those questions. Many people, many of our liver patients, they worry about safety. They worry about whether the thrombosis is related to the liver and something like that. I think the way we can do is to share with them the most updated data, the experience from other parts of the world, and also tell them what the evidence tells us, and then to try to counsel them, address the concerns. If they have some particular concern, hopefully we can use the data to let them know, to relieve their concerns and show them the evidence. I think that would be very important. So if some of our audience, you can read Chinese, you may be interested to visit our websites, because we also prepare some very short video to educate our liver patients about the vaccine. So mainly to tell them that would be, in fact, we support them to receive the vaccine and how to define efficacy and safety, something like that. So if you're interested, you are more than welcome to visit our website to watch our very short video on this topic. So with that, I thank you very much for your attention.
Thank you very much, Grace. Another wonderful talk from you, and I think we learned a lot about how we should deal with our patient with liver disease with vaccinations. I would like to go ahead for the next talk by Dr. Mata from UK on the observational studies of COVID-19 vaccinations and outcomes of liver disease populations in the UK and Europe. Dr. Mata, please.
Thank you very much for the invitation, and hello from London. Good evening to you all in Asia. Yes, thank you so much to the APASL board for inviting me to talk about outcomes from observational studies in Europe and the USA in particular. So what I'm going to talk about today are the outcomes that we know about from COVID-19 in chronic liver disease per se and liver transplantation. I think it's worth looking at that briefly. This will build on what Grace has told you already today. I'll tell you briefly about what we think about the potential mechanisms of liver damage in COVID-19, and then we'll talk about what the available data tell us already, and what cohort studies are in progress and what are the future outlooks. I don't have any conflicts to disclose, apart from the only one thing I want to pass on is that there is very little data available for these patients at the moment. So what I'll tell you will be data in progress, really. But let's just take a look back from around a year ago when this pandemic started. The first hint that there was a problem in our liver patients came from Italy, which was one of the first countries to be badly affected, as you remember. And in Lombardy, which was in North Italy, we saw very, very early that there was a problem in liver patients. The mortality at 30 days was very, very high. But interestingly, around a third of these patients had a liver-related mortality rather than typical pulmonary-related decline. And what we see when we look at these patients in more detail is that it was the sicker patients with a high MELD that had problems, and also patients who progressed had a very high Cliff organ failure score. So what we know is that the disease was related to the baseline severity of liver disease, and also the mode of progression was through multi-organ failure, very different to patients without underlying liver disease. And of course, these are data from the registries that were set up. The community did a very good job of setting up registries in Europe and North America. You've already seen some of this data, but patients who had underlying cirrhosis, had worse outcomes based on the underlying severity of liver disease by Child-Pugh score in terms of ICU requirement, organ replacement, or death. And the other interesting thing that we saw in these patients was that, as we know, age was a very marked risk factor in patients who did not have underlying liver disease. But you see this inverse pyramid is completely lost in cirrhosis. All patients were vulnerable to death, whether they were young patients or older patients. So the rationale for immunizing these patients is very, very strong. The mode of decompensation is in patients who have underlying cirrhosis is liver related, particularly with a history of severe underlying liver disease. And of course, compared to patients without cirrhosis, once patients with cirrhosis are hospitalized or require organ support, the risk of death is very, very high. So these data just demonstrate how important it is to have protective strategies for patients with cirrhosis who are very vulnerable to COVID-19. There's also been a lot of data in liver transplantation. These are data from the United Kingdom. And although the signal is not quite as strong, the patients who were in the liver transplant cohorts had higher rates of ICU admission, requirement of organ support, no real signal in terms of increased death. But when we look at pan-European data, there was an increase in mortality, particularly in older patients and those with multiple comorbidities. So both of these populations did require prioritization, and that's, as Grace has told you, this is why they are prioritized in both the American and the European guidelines for the issuing of these vaccines. What I want to focus on briefly is the potential mechanisms of liver injury in COVID-19. And there's been some speculation about how this might progress and how this might cause liver-related decompensation. This was a study from China, again, around a year ago, which, as Grace has told us, showed that liver injury was an independent predictor of outcome in these patients. Now, one aspect of this that was discussed was that there's no ACE2 expression in hepatocytes. This paper showed electron microscopy of potential viral particles within the liver, but there was a lot of discussion as to how this could be. What we now know, and on looking back at the data, is that ACE2 is expressed in chronic liver disease. So it's not expressed in hepatocytes, it's expressed in cholangiocytes in the baseline state, but it's induced in patients who have chronic liver disease. And this is probably why there is widespread cell death in the liver, as you see in patients who develop COVID-19. Our own work has actually looked at the mechanisms of how this progresses, and this is now online, and very happy to talk about that if there's interest. But again, this is to emphasize that in coronavirus infection, there is a lot of hepatocyte cell death when there is underlying cirrhosis, and this may be why patients progress to multi-organ failure. So there is a lot of reason to protect these patients. But what do we know about liver patients? Again, Grace has already told you that there are a number of speakers have told us that there are large clinical trials for the main vaccines that are in use. These are the vaccines we have been typically using in Europe, Pfizer, AstraZeneca, and Moderna. Very large numbers of subjects have been studied in these trials, but of the 43,000 that received the Pfizer vaccine in phase 2-3 studies, only 3 patients had underlying chronic liver disease. AstraZeneca, again, a large number of subjects, chronic liver disease patients were completely excluded. And in Moderna, there are a small number of patients in the trials, but there's no subgroup level data available. So we really know very little about the specific efficacy in these subgroups. And there are reasons to have concerns about the effectiveness. As other speakers have already mentioned, there is a reason to be worried. There is chronic liver disease associated immune dysfunction, both in the innate compartment, but also importantly in the adaptive compartment. And this is part of the reason why we know there are reduced vaccine responses. For example, patients with cirrhosis have very decreased response to pneumococcal vaccine. This is a study where vaccine responses were compared to healthy controls, and there's a reduction of around 20% in the peak levels of IgG at 1 month. But importantly, the durability of this response at up to 6 months post-vaccine is very markedly decreased, almost back down to baseline levels. So this is a very real concern in cirrhotic patients, and similar data are present for all hepatitis B vaccination as well. And the other concern in the literature, although we are yet to have large data to see whether this is a problem or not, is whether in some individuals there could be the potential for toxicity. And one potential area is antibody-mediated enhancement. This is a phenomenon. We see this in dengue fever, for example, whereby if there are low levels of neutralizing antibody, so if the immune response to a previous vaccine or a previous infection has been poor, such that the antibodies are poor quality, there's low number, or they don't neutralize and opsonize for phagocytosis well, then these virus antibody complexes are not removed. They can remain in the circulation, and they can actually non-specifically induce immune responses through the Fc gamma receptor on innate immune cells, leading to paradoxical pro-inflammatory responses through TLR3, TLR7, TLR8. So I want to emphasize there's been no data to suggest that this is a problem, but I don't think we yet have significant data in, for example, cirrhotic patients or patients who have other chronic disease who have yet been exposed to COVID-19 after vaccination. And so this really reinforces the need for vigilance in our populations. So where's this going to come from? This will come from real world data in particular, and potentially the setup of registries to look at liver patients and liver transplant patients in more detail. These are UK data that are population level. They're not liver disease specific. I wanted to share this because it's very new. It's only from last week. You've already heard that the UK is doing quite well in terms of vaccine rollout. We have a large percentage of our adult population, over 50% now, vaccinated. These are data looking at seroprevalence of antibodies to N protein and spike protein. Of course, spike is what's going to tell you about vaccine response. The N will be the underlying baseline level of seroprevalence from natural infection. These are the various age tiers, and you see that the acquisition of anti-spike antibody following induction of vaccination programs in the elderly patients first, followed to the 60 to 70-year-olds and the 50 to 60s, we see levels that approach 90–95%. Very high levels, consistent with what we see in the clinical trials, all very encouraging. But of course, this is the whole global level rather than a subgroup analysis. The other interesting population level data that we can tease out from the United Kingdom is something to do with durability. Now, you may not know, but in the UK, we have delayed our second dosing for some weeks across the population, regardless of the brand of vaccine. So we are waiting for 12 weeks now to give the second dose for all populations, whether they are high risk or low risk. And what you see here is after one dose, the odds ratio of infection, again from population level data, so large numbers. This is the Pfizer data, this is AstraZeneca. And you see the odds ratio for infection is cut, as you'd see, consistent with the trial data again. And this persists up to around 10 weeks or so after infection. But after 10 weeks, particularly with the Pfizer, and again, slightly with the AstraZeneca with these larger error bars, you see a slight potential waning of effectiveness. So this gives us some idea about durability of response. And I know there are many discussions about whether further booster doses or third doses are going to be required, and maybe that's something we can talk about. Okay, so what about in our liver patients? As I've already said, there are very few data around, but there have been some published over recent months. This was published in JAMA. This is from a group in the USA. And what this group looked at was the antibody responses from a single dose at this stage, a single dose of mRNA vaccine, both Pfizer and Moderna. So the data represents all transplant recipients, both solid organ and hematological. But if you look at liver patients, the data are quite striking. Of the 78 patients here, only 28, so around a third, had any detectable antibody serological response to a single dose of mRNA vaccine. So very different from trial data in healthy individuals. And this group have recently published again a follow-up letter in JAMA looking at now the data following the second dose in the same large cohort of transplant recipients. What you see here on the left, this is all organ transplant recipients. This is the increment in anti-receptor binding domain. This is the increment in anti-spike antibody from individuals who had a baseline detectable antibody. The orange spots are those who had an undetectable level at baseline. But what you see is that a significant number still, after 2 doses, have no detectable antibody responses. A large number do now have a response, but again, these numbers, there was no control group here, but these values are very much lower than that's reported for healthy individuals. Very importantly, we don't know what the surrogate marker for protection is in terms of a value to provide adequate protection or durability. Sorry. And in the liver population, you see that the proportion that have no antibody responses after 2 doses still is 26 out of around 120. So around a 5th to a 6th still. So these are really quite concerning data, I think, for liver transplant recipients. And it's also backed up by real world data from Israel. As you know, Israel are also very advanced in their transplant program, in their transplant vaccination program. And these data are published in Journal of Hepatology quite recently. Liver transplant recipients versus healthy controls here, importantly, who all received 2 doses of the Pfizer-BioNTech vaccine according to the licensed schedule. But the numbers, again, are very striking. 100% of healthy individuals had a positive anti-response versus less than half of those from the liver transplant population. And of those that did receive the vaccine and had a positive response, the absolute values are also much lower, as you see here. Of course, the caveat is we don't know what the value for corollary of protection is, but still concerning nonetheless. They went on to look at the individuals who didn't respond. As you may expect, there were those that were slightly older, were on more immunosuppression. But again, there is a need to look at these populations in more detail. Now, so I've looked online at the open studies that are looking to establish prospective registries for liver patients. There are 3 that I could find on clinicaltrials.gov. There are actually 2 in Asia, I understand, 1 in Hong Kong, one in India. But here in Europe, we're also looking at this population in more detail. It's obviously an urgent need. The consortium is represented by the European Foundation for Chronic Liver Failure, ELITA, the European Liver and Intestinal Transplant Association, and the Foundation for Liver Research. And we are conducting a pan-European observational study to answer this question. And so we're sampling patients at baseline, also within a window around 6 weeks to 7 weeks after the final dose of vaccine, and then later around 8 months or so. But of course, we need to collect real-world data with clinical endpoints as well, up to around 1 year. The incidence of these events is quite low, so our sample size is around 3,000, and this study is open and recruiting now. I understand there is a study open in India, as I say, and a study in Hong Kong that seems to be opening very soon as well. So just to summarize what I've told you today, we know that COVID-19 is associated with poor outcomes, particularly in cirrhotic patients for whom we have very little data about the efficacy of the vaccine. The mode of disease progression is slightly different in liver disease. It's reflected by decompensation of liver symptoms in a number of patients and sometimes progression to multi-organ failure. This is probably due to hepatocyte injury, which does not occur in the non-cirrhotic patient. There is very limited vaccination data for chronic liver disease or liver transplant patients, and we need prospective cohorts urgently. We have one in Europe called Cobalt, which will report in 6 to 8 months, and I hope we'll have similar data that we can discuss again from Asian cohorts as well. So with that, thank you very much. Please feel free to contact me if you'd like more detail on anything I've said. Very happy to discuss what we've talked about today.
Oh, thank you very much, Gautam, for the excellent talk. So I think we have 10-15 minutes for discussions, and I hope the speakers will be with us. And we have quite a few participants in the webinar. In fact, we have a few questions already raised by the audience. And one of them is whether this AstraZeneca vaccine associated thrombosis should be of a concern if we use these vaccines in patients with portal hypertension or even portal vein thrombosis. So maybe Gautam, can you reply to this?
Sure, can you repeat the question? I'm sorry. Professor Lau. Just
AstraZeneca vaccines related with thrombosis,
Yeah.
whether it is safe to be used in those patients with portal hypertensions or even with
Yeah.
those with portal thrombosis.
So this is a very real concern for the patients, as you imagine. There's a lot of media interest in these complications in the UK, and also, of course, the Johnson & Johnson vaccine has been associated with the same. The overall incidence of the PF4 antibody-mediated immune-related thrombosis is very, 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 very low, as you know. And so I think the first message to anyone listening to give to their patients is that the overall incidence is absolutely tiny. The risk for cirrhotic and liver transplant patients is very, very high. So the risk benefit is clearly towards vaccination. I think it probably is worth saying, though, that the second most common site of thrombosis was splanchnic in the published data. The most common is cerebral in the published data, but the second is splanchnic. So there is the potential for harm if this occurs in our cirrhotic and transplant patients. We have anecdotally seen data of cirrhotic and transplant patients having this problem and having complications. And I don't know whether any of the colleagues have data or at least cases that they can share. And we are asking everyone in the European consortium through Cobalt to report their cases to us, and we will have something hopefully to present in a week or two. The overall answer is that we don't know at the moment. The risk is certainly not related to underlying thrombotic potential, because cirrhosis is prothrombotic, we know, but the mechanism is specifically immunological, and there's no data to suggest that it's higher at the moment in cirrhotic or transplant patients.
Would that affect your recommendations to the type of vaccines in those patients with chronic liver disease and portal hypertension? Would it affect
at the moment
recommendations? The choice of Pfizer or AstraZeneca.
Yeah, I think at the moment, absolutely not. The absolute incidence that we know is very, very low. The risk benefit is skewed very much towards vaccination in these populations. I think delaying vaccination because of a theoretical concern and the potential availability of a non-adenovirus vaccine would be more deleterious to these patients at the moment. But it does reinforce the need to collect data, and that's why this webinar, for example, is very useful to connect us so we can share these data as it comes available. At the moment, no.
All right. In fact, I'm wholeheartedly encouraging people like you, youngsters, and Grace, and Vincent is not around, to collect data, because we have tons of data, and we need to have find an answers and to have the data analyzed properly. Now, the vaccine is coming rapidly. The COVID-19 comes rapidly, and then we are seeing some good news with the vaccinations in places like Israel. In Hong Kong, the vaccination is picking up, and unfortunately, I learned from South Korea, the vaccine is not really getting up rapidly. There are lots of hurdles, and I think that one of the key issues for the webinar and in our practical values is really about the safety, because people are afraid of all the safety concerns, and I think this is the major hindrance. And maybe Grace would like to enlighten us of how you get through with all the hurdles. I'm sure lots of people come to you. And are you vaccinated already, Grace, yourself?
Yes, I am.
Great, because you are still a fertile person, fertile females, and this is a great reassurance, and a mother of already 3 kids, right? So what is your personal?
Yeah, I think Professor Lau pointed out a very important point that, in fact, many of our patients do worry about the safety, especially our media usually highlight one or few cases of like major side effect mortality after vaccine. So I think when the patient come to ask me, I would just share with them the data, telling that there's no obvious safety concern, in particular in patients with liver diseases. But I will also like to make sure that their most updated liver assessment have been like very stable, and tell them your liver condition is very good. And in fact, even in patients with like decompensable liver condition, in fact, the guidelines also will recommend them to receive the vaccine. In fact, these patients should really get protected as soon as possible. So I will try to explain to them, tell them the evidence, tell them what the international society recommend, and hopefully give them some confidence about what the experts will advise them to do. Okay, thank you.
Thank you very much, Grace. Professor Kuhn, One of the burning questions has often been asked is about measuring the efficacy of the vaccine itself. We read the data about New England and so on, about Moderna's and BioNTech and so on. But how about the antibody measurements? How effective it is? What is the correlations? What type of antibodies are we talking about? Would be effective in preventing the disease or infections or the disease progressions itself.
You mean?
Yeah, the antibody. Yeah.
Antibody.
Yeah. What antibodies you would like to prefer to the measures? I mean, which epitopes?
Actually, we don't have commercially available antibody test in Korea. We just can check by in the clinical trial or just by the experimentally. So, do you have some commercially available antibody check kits for the patient in your clinic?
Yes, we do. But then the problem is always there's no evidence that the antibody we are measuring is protective at all or effective, especially when we talk about the variants. So how would that translate into clinical efficacy? Anybody from the panels who could answer this question? Because we are talking about protections. We are talking about, very importantly in life, we want to have the borders open up. And I think one of the key issues is not just vaccinations. Well, people will be talking about if you have the antibodies, you can travel freely without quarantine and so on and so forth. So I think this is a burning question. Any brilliant answer to these questions, which is of practical value? We want to travel.
Yes, I would like talking about antibody measurement. There are two types of antibody. First one is binding IgG antibody, which is targeting spike protein. The other one is neutralizing antibody, which is actually correlate of protection against COVID-19. Neutralizing antibody is measured by plaque reduction neutralizing PRNT, which is so sophisticated and which is time consuming and labor intensive, which is only done in the virology laboratory. So it's not usually available in the real situation. So IgG binding antibody is will be checked by commercial kit. So, but the immune passport should be demonstrate the protective antibody. So it is not easy to perform neutralizing antibody test usually. So still we have some discussion in this topic.
So what do you think would be the directions for us to go? We need our life to carry on, and we have been in lockdown, in quarantine for 18 months now, and the economy is being hurt badly. The Olympics is being postponed. What would be your thoughts about how we can select those patients out and allow them to go freely?
Maybe Professor Won-Seok Choi will answer the question.
Yes, actually, as I know, the immune correlation of protection has not been established for the COVID-19 vaccine until now. So we can't use the antibody test for the evidence of the immunity. But as I know, the immunity level for the protection may be quite lower, as I know. And I think that the certification of vaccination can be substitute for the immunity because in case of yellow fever, the vaccination record is used for such a certification. So I think that the vaccination certification can be used for such a case.
Well, So is it available in UK or in Europe, South Korea? What is the?
I think it's a very important discussion to have, because there is so much confusion about what antibody testing means and what the correlate of immunity is. As we just heard from Professor Choi, there is no correlate from the data available about antibody levels. But of course, the problem is the kits are, first of all, some are qualitative, not quantitative. They give you a binary positive, negative. It's completely useless for measuring a correlate to infection. And then some commercially available tests measure spike, some measure nucleocapsid. Again, if you're measuring N protein, you're not correlating at all with vaccination efficacy. So it's a very active area of discussion as we open up. We're opening up in the UK, but as we heard, I don't think there's a strong basis to use these tests to open up. So I think it has to be based on vaccine efficacy. But of course, we're still in a position whether for vulnerable populations, whether a third dose is required. In many countries, France in particular, they're recommending a third booster dose for vaccine for transplant recipients. So, I think that we'll see the space move very quickly, which is why we do need guidelines to be updated rapidly.
Right, but what is the basis of the third dose? I mean, so if you are trying to measure antibodies on not the efficacy, what is the base? I mean, you're building up more antibodies, and does it translate into real efficacy and protection?
I completely agree. It's in France. It is pragmatic. It's based on expert opinion, and there will be embedded observational studies that will answer that question. So they have chosen to go first in Europe. They're the only country that's recommending it. But of course, it's based on expert pragmatic opinion. Many countries are embedding studies. In the UK, we have a study which would be phase 2B of a third dose in some populations. So different countries take different approaches. We need to move rapidly, as we heard from the first talk. Things are being done in parallel in the COVID era, and I think that's why.
Professor Choi, could you enlighten us with the vaccine development? You have given excellent reviews of how the vaccines was developed and the current status. So what will be the future? Because we heard a lot about probably we will need vaccinations in the subsequent years to come, every years to come, with the variants and so on. So what is the current development pipelines for the vaccines, and what are we going to expect in terms of safety and efficacy and so on?
I think we need a booster shot for in terms of the waning immunity and the immunity against the variants, because the neutralizing activity is really reduced against the variants. So the virus is evolved to the variants and escaped from the prior immunity. So we need another kinds of strategies to combat the variant. So as I know, there's two ways to combat the variants. The first is to use the same vaccine for the booster shot, because it can boost the immune level to above the level of ICP, but it is not established. But as I told you, that the level may be quietly low. So if we use the same vaccine as a third dose, it can boost the immune response quietly above the ICP maybe. And the other strategy is to develop the vaccine against the variants. So there are two strategies going together. We don't know which will be win, but I think that from the near future, the same vaccine will be used, but from the far away, we must use the another kinds of vaccine maybe.
Yeah, Professor Kim, you have anything further to add?
I think already Pfizer and Moderna and AstraZeneca, they are developing new vaccine against the variant, such as South African variant. Especially South African variant demonstrate markedly decreased neutralized activity against serum from vaccinated people. So we'll know the autumn or winter season of this year. We'll know the whether we need another third booster shot or not. So we'll see the result end of this year. I have one question. I'm sorry. I have one question to Professor Mehta. In South Korea, we are using AstraZeneca vaccine and Pfizer, very similar ratio. I wonder whether TTS, thrombosis with thrombocytopenia syndrome is occurred mainly in Caucasian, European, and North American people, because we have some thrombosis, several thrombosis case after AstraZeneca vaccination. But Korean CDC, they announced there is no thrombocytopenia, even though people have cerebral sinus, venous sinus thrombosis, CVST, or pulmonary embolism. But there is no thrombocytopenia was demonstrated by Korean CDC announcements. So I think there is some atypical or variable clinical manifestation of TTS depending on the ethnic or race. Do you have any idea about this matter?
It's a very interesting question. We have a number of cases that have come through our institution here in London. They are, I think all of them have been Caucasian. But in terms of whether there is thrombocytopenia or not, the other thing to say is that we can assay for the PF4 antibodies now. I think it's very important to, because this condition is quite rare, to test for PF4 antibodies before ascribing causality to that case. And these tests are available. There's a very nice letter in the New England Journal of Medicine, I think published yesterday or today, that outlines a very scalable assay for PF4. So I think it's important that we make sure we're identifying a true case of this syndrome rather than incidental thrombosis.
Right.
Unfortunately, Korean CDC, they do not have anti-PF4 antibody assay test yet. Next month, they will get the antibody test against PF4. So I'm very curious about this matter.
Yeah, I think it's very, very important to be able to test causality, for these cases and to monitor properly.
Thank you.
We have a question from Professor Sharma from India. The question is, in people who do not develop the even binding antibodies after weeks of vaccinations, do you suggest a booster third dose? And I think this is of relevance, especially in India. So if there is no binding antibodies developed after 2 doses, do we give the third dose a booster? Or is it useless? Any data on this aspect?
There's no data. And of course, it's also outside license for these vaccines. So I think it's important we answer the question. This will have to be done in a phase 2B study, really, at least in Europe. That's how we would it. We're doing that. I know in Germany that exact study will start soon. It can't be a phase 4 because it's outside license, like I say. So at least in Europe. So but it's really important data. You saw that a large number of patients with liver transplantation have null responses. So I think it's a very important study to do.
Well, questions from Professor Daniel Chauvel from Israel. I think this should be directed to Professor Grace Wong. Adverse reaction to vaccinations has been experienced in Israel, and Professor Chauvel said encounter patients who have no liver diseases and start to develop the abnormal ALTs and alkaline phosphatase. He has recently encountered 3 such patients in Israel. So Grace, would you like to address to Professor Chauvel from Israel?
Okay, thank you, Professor Lau, and thank you for the sharing of experience. In fact, I also have some of my colleagues sharing similar findings that quite healthy subject and that have raised liver enzymes after vaccine. I would have to say that we are still gathering experience. I would say in general, the incidence should be quite low, but from time to time we encounter scattered cases about that, and most likely the mechanism behind should be some kind of immune mediated. But I think we still have to, like, as we work out for patients with abnormal liver enzyme, we still have to exclude other things like viral hepatitis, like autoimmune diseases, and monitor whether the condition would be just transient, and if there's remain persistent, maybe a liver biopsy would be helpful. But I would guess that most likely there would be some immune-mediated response. Yeah, thank you.
Well, in this connection, in fact, Professor Tang Shuksham from the Singapore also want to address on these issues. He asked whether there is a possible pathophysiology of jaundice and pruritus and severe hepatitis, but negative autoimmune markers after a few days of receiving mRNA vaccinations. So I think that we are seeing the noises, bits and pieces around that liver injury does happen after the COVID-19 vaccine. So what do you think? I mean, he said it's the negative autoimmune markers. So what is the autoimmune markers you are trying to measure? Or you would like to measure? So any experience from the practical side? Liver biopsies, investigations into those liver injuries? I haven't seen any here in my center. Probably when we are not monitoring enough. But severe hepatic decompensations, any experience of, no? Okay.
So we've not seen that, and we've done a large number.
Yeah, because data is go ahead.
It's very difficult to find causality, of course, as well. Anyway, these patients do decompensate if they've got underlying liver disease. We've seen one patient who developed acute cellular rejection following mRNA vaccination who did develop positive antibodies, so there was immunogenicity from that vaccine. So this is a transplant patient, but again, very just one patient, difficult to tell causality. We just need to log and share these data. In our experience in our center and in other UK centers where we've done large numbers, where there is not a strong signal of this problem.
Well, there are a few questions related to the use of vaccines in those patients treated with biological therapies. So I think that's related to the use of targeted therapies or the immunosuppressive therapies. And I think it has been addressed in your talk, Mahita, means how they respond. So in general, what do you think? They respond adequately as usual, or we want to have a booster vaccinations?
So again, I think the early data suggests that immunosuppression will blunt responses. You saw from the Journal of Hepatology paper from Israel that an independent risk for blunted response was immunosuppression. So, similarly with biologics, drugs like rituximab, etc., will of course very likely blunt that response. And I think we'll see guidance coming from a number of institutions that they'll recommend booster doses for these vulnerable populations. That's my personal opinion. Of course, the data is coming. That's my opinion.
Right. Any further things to add, Professor Kim, before we close the webinar? Can't hear you.
Sorry. My suggestion is one of increasing immunogenicity among the patient with transplantation or chronic liver disease. I suggest the adjuvanted COVID-19 vaccine, such as Novavax vaccine. Novavax vaccine is finished third phase clinical trial, but not authorized yet. But Novavax vaccine include matrix M adjuvant. Adjuvant acted increasing immunogenicity and broad spectrum coverage. So I think your hepatologist think about the Novavax adjuvanted vaccine for the patient with liver transplantation or immune suppressed liver disease. Thank you.
Thank you very much. Shall we have our president, Professor Yan, to close the webinar? Professor Yan.
Okay, thank you, Professor George Rao and Professor Ujigem and many speakers. We, as I told you, we got a vaccination for COVID-19 is a Global Hepatology Society Summit at the 1st and May. As I told you, in the we must get the vaccination in the liver disease patients, even though they are decompensated liver cirrhosis and liver cancer and so on. So now from this vaccination webinar, we talk about many knowledge. We get many knowledge about vaccination. So we can recommend to our liver disease patients for the COVID-19 vaccination. So thank you, Joanna. Again, thank you. Very much, thank you.
Thank you, everybody.
Yeah,
And I think
yeah,
we
close
all
to-
agree. We need to have everybody vaccinated, especially those with liver diseases. I think that's the concluding remarks. And we have to stop the COVID-19 as soon as possible.
Yeah.
Thank you very much.
Thank you very
Thank you
much.
all.
Thank
Bye.
you.
Thank you.
Thank you.
Bye-bye.